have them printed. So, again, thank you all for, I'm happy to be here. Thank you all for being here. Even though I work in HIV STD programs now, I've been sort of directly and indirectly affiliated with the hepatitis programs for many years. Um, and I think that in many, many years, when we look forward, we'll see that the hepatitis, especially hepatitis C and hepatitis B programs, will look a lot like HIV as sort of the public health implications of those epidemics evolve over the next few years. So I have just a couple broad topics today, some background, an overview of the Hepatitis National Elimination Plan, and some concepts for a promising future. So what we know is that millions of Americans have viral hepatitis. It is a massive public health burden, a major cause of mortality and morbidity, diseases that have substantial health inequities, and there's an extreme disconnect between the burden, the attention, the advocacy, and the resources. We know that many fewer people are diagnosed with HIV every year than hepatitis C, yet the capacity for local advocacy, for prevention and treatment programs, for care coordination is significantly different. But there's a lot of opportunities for public health. And I'm going to focus a lot today on hepatitis C, but of course, these are also applicable to hepatitis B and hepatitis A in a way that we have never seen before in Michigan. And likely the reason why we're here today and the reason why we're here last year is that because the opioid crisis has brought all of this to light. Of course, we know that hepatitis C has affected injection drug users, people of color, people in urban areas for a very, very long time. But the numbers have changed substantially and expanded to a suburban and rural, frankly, in a white population, and that has brought attention to hepatitis C like we have never seen before. The media and public and policymakers have brought awareness to the hepatitis epidemics in association with the opioid crisis and have highlighted the lack of substance use and mental health services for people who use drugs, the lack of opioid prescribing practices, the lack of healthcare capacity, especially in rural areas, to deal with not only issues of addiction and mental health and substance abuse, but also hepatitis C treatment and prevention, rates of opioid use among women of childbearing age, and the importance of overdose reversal and naloxone use. So in this graph, this goes from 2004 to 2014, but if it went all the way to today, the projection would be the same. This is looking at two populations, opioid injectors between the age of 18 to 29 and 30 to 39, and then the corresponding hepatitis C rate. So you can see how those, not only is that an astronomical increase in number and rate, but also highly associated with each other. This is a graph produced by CDC which shows clustering of overdose by county, so a heat map of overdose by county, along with a heat map of hepatitis C infections by county. And you can see how we have a lot of clustering in parts of areas of the West, a lot in Appalachia. We see pockets in sort of like New Hampshire, Vermont, and up in the Northeast, and then in a significant part of the upper lower peninsula of Michigan. Several years ago now, CDC developed what I kind of call a mathematical model, sort of a projection of areas that look like they have an environment that is conducive to a hepatitis or HIV outbreak. And that is related to counties that look like Scott County, Indiana, which is a county in southern Indiana that had an extensive outbreak of HIV and hepatitis C in an injection drug using community. And so there are about 200 counties that were identified nationally that had this sort of profile, and Michigan has 10 or 11, all clustered in sort of northern lower Michigan. And one of the really huge implications of hepatitis C is, of course, hepatitis C is curable now, but curing hepatitis is complicated, financially complicated with insurance restrictions, complicated with access to treatment and health literacy and all those reasons. But the reality is that hepatitis C continues to cause death, substantial death, and that the number of people dying every year from hepatitis C related causes of death has increased all other nationally notifiable conditions combined, the death rate for all those combined. And this will do nothing but increase in the next 20 years without a substantial push to treat people. So I want to talk a little bit about the national strategy. This was developed last year, and this is a quote from the national strategy. Most of the barriers to preventing and treating viral hepatitis could be seen as consequences of another, more basic problem, in that viral hepatitis is not a public priority of the United States. They cited that missing from the response to the opioid epidemic is awareness and advocacy to the infectious disease consequences of injection drug use, to the lack of resources to support hepatitis education, prevention, testing, linkage to care, and treatment barriers, the limited availability of syringe service programs and medication-assisted therapies for opioid addiction, and a comprehensive and coordinated approach among all stakeholders. This is something Joe and I know very well. There's a lot of people that are working in the area of viral hepatitis, but they're ranging from Medicaid to behavioral health to public health to, frankly, HIV programs, and so there's a lack of a coordinated and comprehensive approach. So this is what the National Strategy for Elimination of Hepatitis B and C looks like, and there's the website for you to look at. It cited several important things. One is that we have the tools to eliminate viral hepatitis in the United States, certainly through vaccination for hepatitis B and hepatitis A, but curing hepatitis C and if certain people aren't eligible for curing or are unable to get a cure through hepatitis C, prevention programs for hepatitis C work. The report cited that with elimination of hepatitis C and B as public health threats by 2030, over 90,000 deaths could be averted. And the report creates visions and offers targets. And sort of in response to that, CDC created the progress towards viral hepatitis elimination. I guess it's sort of like a CDC dashboard in response to that. I'll show you that in a minute. So their recommendations included a coordinated effort to manage hepatitis elimination, infrastructure to support hepatitis case finding and surveillance, studies to measure Hep B and C incidence and prevalence in high-risk populations, expanding access to adult Hep B vaccination, and that all hepatitis B surface antigen positive pregnant women have early DNA liver enzyme tests, expand access to syringe exchange and opioid agonist therapy, and identify settings for enhanced viral hepatitis testing. In addition, they recommended that public and private health plans remove restrictions that are not medically indicated and offer direct acting antivirals to all Hep C patients, that we establish Hep B vaccine birth dose measures, we build capacity of primary care to treat Hep B and C, especially important in rural areas. We build a comprehensive system of care and support for special populations on the scale of the Ryan White system. Just for those of you that aren't involved in Ryan White, that's the program that we oversee. And Ryan White is a highly well-funded program that comes from HRSA that offers everything from early testing for HIV, intensive case management, medical case management, literacy, nutrition, transportation, every wraparound service that you could imagine, access to medications if you're uninsured, not only HIV medications, but all the other medications that you may need to stay healthy, including mental health or other chronic disease medications throughout your entire lifetime. So that's sort of what they're referring to. I think a big gap in a lot of our conversations nationally and locally is the involvement of the criminal justice system in identifying, treating Hep C. So their recommendations were that the criminal justice system should screen, vaccinate, and treat hepatitis B and C according to clinical guidelines, and that the federal government should purchase rights to antiviral use in neglected market segments and negotiate drug prices down, as they certainly have for other drugs. So in response to that, CDC made a dashboard. It's not really great news, so Um, but they have created these metrics that you can read on the hepatitis website. Certainly, we all know that hepatitis A, the rate of infection is increasing not only in Michigan but nationally. And then they have a few other metrics. And I think the reality is that in the next few years, all of these are probably going to go up before they go down. But I think we have a lot of reasons to have a really hopeful future. And for those of you that have worked in hepatitis for a long time, the reality of hepatitis treatment is a completely different ballgame now than it was. Hepatitis treatment years ago practically disabled people with the side effects. We have treatments now that can cure 95% of people within 8 weeks on a very tolerable regimen compared to what it used to be. And that's a wonderful thing. We talked for many, many years about how Hep C treatment costs $100,000. Costs $100,000, and it doesn't anymore. It absolutely does not. And you can see that those drug prices are reducing every year, and that's really important. We've seen several successful models of hepatitis C treatment being comprehensively approached through health systems. So the Department of Veteran Affairs have treated over 92,000 Hep C infected veterans since 2014 and have achieved a cure rate of more than 90%. You can see that graph on the right. The Indian Health Service also through the Cherokee Nation has screened over half of their adult population and successfully treated 1/3 of all those that are Hep C infected. But what we know is that in order to achieve that for general populations, that you have to have a comprehensive HIV care continuum and coordination. You have to prevent people from getting Hep C. You have to identify the people that do have Hep C so that you can link them to care and help them achieve a cure. And I think all of us are really realistic in this room that heroin and opioid addictions are incredibly powerful addictions. We're seeing those as a chronic disease with realistically a very high statistical reality of relapse over a person's lifetime. And so treating Hep C infection means you have to really work hard to prevent them from getting reinfected. And so that lifetime care continuum is something that I think we have a lot of work going on in a couple of those boxes, but there's a lot of boxes yet that we haven't even started yet. And so while I was ending on a hopeful note, I also want to talk a little bit about, the concept that hepatitis C could look like Ryan White in that system in several years. But the reality is that we financially have, I think, all the tools we need to prevent HIV infection in Michigan. We have biomedical interventions. You can get a free HIV test in any county in Michigan. You can get access to free medications. You can get case managers. And the reality is people get HIV every day. And even the people that have all these services, still not 100% of them achieve viral suppression. And there's a lot of things going on there like mental health, like racism, like stigma, like health disparities and sociodeterminants of health. And even in a perfect model, it's still really hard. And we know that that's going to be, I think, probably, frankly, even truer with hepatitis C down the line. But I do think you can see how significantly improved all of the health outcomes are at every column along there in terms of diagnosis, care, retention and care, and achieving viral suppression. And that the outcomes are higher for people that receive this comprehensive care continuum services. And I think that's all I had this morning. Does anyone have any questions for me? Go ahead.
I saw that one of the graphs earlier in the presentation about kind of modeling for the county in Indiana
Mm-hmm.
for risk for having
Yep.
outbreaks. I was just curious because none of them ended up in the Upper Peninsula. There was an interesting article
Yeah.
in Detroit Free Press yesterday
Mm-hmm.
talking about
Rates.
the opioid
Yeah.
epidemic is just
Yeah.
out of control.
Yeah.
So is it just because there isn't a population?
Would you guess that the model doesn't have enough people up there to sort of push it into statistical significance? Yeah, probably true. And frankly, Joe and I are very, like, we know this, we know the person who wrote this very well. Like, we're very, very, very familiar with the metrics of this. This has been extremely important for advocacy and for awareness and for getting attention to these counties. The reality is that those are very rural counties, and we always want to remind people that Macomb County or St. Clair County have, without a doubt, a much higher number every year of Hep C infections. So, this is important because it shows a burden in a population, like in a small population of a very tight drug using network community. However, the reality is that we have epidemic levels of new Hep C infections in certain counties of Michigan that are not necessarily up there.
Yeah, so if we have questions, we can just raise our hands. I can bring the handheld mic around. That way we get it on the webinar. So if you just want to repeat your question real quick.
Sure.
Sorry.
So my question was just in terms of the modeling that was done at CDC, looking at rural counties with that would be at risk for these HIV and HCV outbreaks because of their similar to what was seen in Indiana. I was just curious that none of the counties in the Upper Peninsula had made it up there since they have a really big opioid outbreak going up there, but it sounds like it's population.
Thank you.
I'm going through my notes to make sure I didn't miss anything. No. Okay.
Any other questions?
Okay. Thank you.